Successful teams not only have medical expertise and mastery of resuscitation skills, they also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible. Let's review those now. Closed-loop communication. This is important for both the team leader and team members. When the team leader gives an order, the team member should confirm that he or she heard and understood the order. The team leader should make sure the team member understood the order before assigning additional tasks. Clear messages. Using concise, clear language helps prevent misunderstandings. Speaking in a tone of voice that is loud enough to understand, but also calm and confident, helps keep all team members focused on the task at hand. Clear roles and responsibilities. When everyone knows their job and responsibilities during a code, the team functions smoothly. The team leader should clearly define and delegate tasks according to each team member's area of competence. Know your limitations. Every member on the team should know his or her limitations, and the team leader should be aware of them. Ask for assistance and advice early, not when the situation deteriorates. Knowledge sharing. This is a critical component of effective team performance. Team leaders should ask for good ideas for a differential diagnosis and frequently ask for observations from team members about possible oversights. Constructive intervention. Sometimes a team member or the team leader may correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you have to correct a colleague who is about to make a mistake, whether it's a drug, dosage, or intervention. Summarizing and reevaluation. Summarizing information out loud is a good way to maintain an ongoing record of treatment and acts as a way to reevaluate the patient's status, the interventions performed, and where the team is within the algorithm of care. This technique can also help team members respond to the patient's changing condition. Finally, all team members should display mutual respect and a professional attitude to other team members, regardless of their personal expertise or training. It's important that the team leaders speak in a friendly, controlled voice, avoiding shouting or unnecessary aggression. Not only is it important to know what to do during a megacode event, it's as important to know how to work together as a team during the code. Reviewing how a code went not only helps individual team members perform better in subsequent codes, but may also bring system deficiencies to light. Now we'll play the Megacode resuscitation case study again. This time, as you watch, look for the key elements of effective team dynamics. Closed-loop communication, clear messages, clear roles and responsibilities, knowing one's limitations, knowledge sharing, constructive intervention, summarizing and reevaluation, and mutual respect.
The patient's gone into VFib. Start chest compressions.
Starting compressions.
Mandel, you'll be on defibrillator. Shelley, you'll be recording.
Recording.
Sam, you'll manage the airway. Dana, have you been able to establish an IV access yet?
I've tried several times, but it's failed.
Okay, let's move on to IO access, please.
Moving to IO access.
24, 25, 6, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Charging at 200 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
I have IO access now.
Great. We'll continue CPR for 2 minutes and evaluate the need for additional defibrillation. Shelley, I'll rely on you to monitor the quality of the chest compressions. Dana, you'll need to draw the drugs up before each rhythm check, so if the arrest persists, we can move quickly to drug therapy. Let's begin with 1 milligram of epinephrine.
Drawing 1 milligram epinephrine.
2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient remains in VFib. The protocol for this biphasic device is escalated dosing. Let's shock again at 300 joules.
Shocking at 300 joules. Charging. Clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
Continue CPR.
Continue compressions. 1, 2, 3.
Dana, please give 1 milligram of epinephrine.
1 milligram epinephrine. And the IO is flushed.
Great. We've given 2 shocks and given 1 milligram of epinephrine. The next medication to consider is amiodarone. Dana, please prepare 300 milligrams of amiodarone.
Drawing 300 milligrams of amiodarone.
Sam, are you getting good chest rise?
Yes, and I'm being careful not to deliver ventilations too quickly or forcefully.
Okay, great. Let's continue there.
2 minutes.
Okay, let's analyze, switch roles. Okay, the patient is in persistent VF. Let's shock again at 360 joules.
Charging at 360 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3, shocking. Shock delivered.
Continue CPR.
Continuing CPR. 1, 2, 3, 4. We can give amiodarone now?
Thanks, Shelley. Dana, please give 300 milligrams of amiodarone.
Okay. 300 milligrams of amiodarone given. And the IO is flushed.
We've given 3 shocks. After the second shock, we administered 1 milligram of epinephrine, and we've just given 300 milligrams of amiodarone. Our next drug will be vasopressin. Dana, please prepare 40 units of vasopressin.
Drawing 40 units of vasopressin.
12, 13, 14, 15, 16, 17, 18, 19.
Let's review any reversible causes by considering the H's and T's.
What about hypovolemia?
That's a good thought. We have IO access established, but no obvious signs of internal or external bleeding. Anybody else have any other suggestions?
Have we considered hypoxia?
Is the airway still patent?
Still getting good chest rise.
She came in with epigastric discomfort and symptomatic bradycardia. Have we considered coronary thrombosis?
That's a great point. Everything seems to suggest a STEMI.
2 minutes.
Okay, let's analyze, switch roles. Okay, the monitor shows sinus bradycardia. Do we have a pulse?
I don't feel a pulse.
Continue chest compressions.
Continuing chest compressions. 1, 2, 3.
Shelley, how long has it been since our last dose of epinephrine?
3 minutes.
Okay, Dana, let's go ahead and give 40 units of vasopressin.
40 units of vasopressin given. And the IO is flushed.
Mandel, your compressions are slowing down. Can you pick up the pace a bit? 2 minutes.
Let's analyze, switch roles. Okay, the monitor shows sinus tachycardia. Sam, do we have a pulse?
I can feel a rapid, weak pulse.
Okay, great. Let's initiate immediate post-cardiac arrest care. Dana, let's get a blood pressure, a complete set of vital signs, pulse ox, and labs. Mandel, let's start a 12-lead ECG, please. Can we check to see if this patient is breathing and responsive?
Ma'am, can you squeeze my fingers? She's still unresponsive.
Still not breathing.
Okay, let's insert an advanced airway and prepare for therapeutic hypothermia.
The patient's blood pressure is 82/40 with a heart rate of 130 and a rhythm of sinus tachycardia.
Okay, the patient is hypotensive. Let's start with a liter of saline. Since we've started with hypothermia, let's use cold saline for the bolus.
Okay, we'll switch out for cold saline.
Tubes in.
Okay, we've got good breath sounds. Let's establish waveform capnography. The O2 saturation is 96%.
Here's the 12 lead.
Okay, she has a STEMI. Mandel, please call the cath lab and tell them that we have a STEMI patient. PCI and hypothermia can be safely combined after cardiac arrest.
In this section of the course, we've shown you the key steps involved in the adult cardiac arrest algorithm, as well as the post-cardiac care algorithm, to promote a positive patient outcome in the event of the return of spontaneous circulation. You've also evaluated the megacode scenario with the key elements of effective team dynamics and structured team debriefing. Combining your knowledge of essential arrest skills with effective team dynamics can give your team a better chance of success with every resuscitation attempt.